Right. Good evening, dear students. Welcome back. We are continuing with our session, that is FMGE Marathon, second day, 1.5 hours today, once again. And this time we are focusing upon one of the important topic which is quite frequently asked. It is about the pharyngeal arches and pharyngeal pouches. Now, what you are looking at is the developing gut tube, the foregut, the pharynx region. And in respect to pharynx, there will be some pharyngeal arches developing. Like in the fish, we will have gills, but we don't have gills as humans. Instead of gills, what we got is called as pharyngeal arches. When we say pharyngeal arches, it will be basically made up of mesoderm, and that too the neural crest cell derived mesoderm, because neural crest cells are migrating in this region, they give some mesoderm which is called as secondary mesoderm. So most of the mesoderm in the head neck region, especially in the pharyngeal arches which are anterolateral, will be neural crest cell derived secondary mesoderm. If you look at the pharynx lateral wall, you will find there are some pouches developing, pharyngeal pouches lined by endoderm. And in the lateral wall of pharynx only, if you look outside, you will be seeing pharyngeal cleft or pharyngeal grooves lined by ectoderm, because outside is ectoderm. So let me repeat the information once again here. As you see, this is the pharynx, basically the primitive pharynx. The gut tube is still developing. And you notice that on the lateral wall of pharynx, this is shown only on one side, say right side. The similar fashion, it will be present on the left side as well. This is just a hemisection. As we are suggesting, we will find there will be pharyngeal pouches. This is pharyngeal pouch number 1. And then there is a pharyngeal pouch number 2, pharyngeal pouch number 3, and there is a pharyngeal pouch number 4 also. We will be drawing a diagram ourselves also to describe the same. But these pharyngeal pouches, they are lined by endoderm. They will be stimulated by neural crest cells. Then they will be giving us some contributions. Whereas on the outside, we'll have the pharyngeal cleft, or what is called as pharyngeal grooves. We suggested this is the pharyngeal cleft number 1. Similarly, there will be cleft number 2, 3, 4, but cleft number 2, 3, 4, they get obliterated. So only cleft number 1 is contributing to structures in the adult. For example, the external auditory canal. The external auditory canal on either side is derived from pharyngeal cleft number 1. Its epithelium will be from the surface ectoderm because it is outside. Whereas pharyngeal pouches, their epithelium will be from the endoderm of the gut tube. So what is the cleft giving? The cleft one is giving external ear canal. And what is the pouch giving? The pharyngeal pouch 1 will be giving us the middle ear cavity, as is evident here. Tympanic cavity is the other name of middle ear cavity. And the eustachian tube, which will be then opening into the pharynx, the nasopharynx. So pouch 1 giving you epithelium of middle ear cavity and eustachian tube. What about pouch number 2? Pharyngeal pouch number 2 will give us the tonsillar epithelium. Tonsillar epithelium is endodermal in origin. Pouch number 2. Pouch number 3, if you remember, yesterday we were talking about pharyngeal pouch number 3. I gave you a mnemonic, PP3 tip. And the mnemonic was suggesting that pharyngeal pouch 3, PP3, will be giving us the T, which is thymus, and IP, which is inferior parathyroid. So as you notice, this is inferior parathyroid and this is the thymus, and they are coming from pharyngeal pouch number 3. They might be missing in a syndrome called DiGeorge syndrome. So DiGeorge syndrome is a problem of pouch 3 and pouch 4. First answer, it's a problem of pouch 3. And they'll be missing thymus. If thymus is missing, you may not be able to train the T lymphocyte, decrease cell-mediated immunity. And if inferior parathyroid is missing, there might be deficiency of blood calcium, hypocalcemia. So hypocalcemia and Decreased cell-mediated immunity is a constant feature of D. George syndrome, a problem of pouch number 3, problem of T. thymus, and IP. inferior parathyroid. But in D. George syndrome, pouch 4 may be also missing, and which is superior parathyroid may also be missing. Now what we do is we'll draw this diagram ourselves to discuss some more details, because you keep getting a question on ultimate branchial body also. So what about this ultimate branchial body then? You see, we are talking about the primitive pharynx here. So let us draw the primitive pharynx. This is the primitive pharynx here, and you are looking at the lateral wall of the pharynx. If you look at the epithelium of the pharynx, it is lined by endoderm because it is on the inner side, so endoderm. Next to endoderm, you will have some mesoderm. Like we mentioned, most of the time this mesoderm will be actually coming from the neural crest cell derived secondary mesoderm. So that is the region where you can talk about mesoderm. Still in the periphery is ectoderm. So let us say this is the ectoderm. Now looking at the lateral wall of the pharynx, you see on the inside there are 4 pouches which are developing. We can show them here. The pouches, let us say this color, pharyngeal pouch 1, 2, 3 and 4. Pharyngeal pouch 1, 2, 3 and 4, not only on the right side but also on the left side, lined by what is called as the endoderm. So pouch 1, pouch 2, pouch 3 and pouch 4. On the inside, lateral wall of pharynx. On the outside you will have the cleft, and we can show the cleft also. This is cleft number 1, 2, 3 and 4, pharyngeal cleft number 1. But 2, 3, 4, they get obliterated. So we don't talk much about them until otherwise there is some anomaly. Only cleft 1 will be persisting, and that cleft 1 will actually form what is called as the external auditory meatus we just mentioned. So cleft 1 on either side, lined by something which is on the outside, that is ectoderm. So clefts are lined by ectoderm, and that is why the cleft number 1, external ear auditory meatus, is also lined by the surface ectoderm. What about the mesoderm? You see, external ear is from cleft 1. Internal, the middle ear is from the pouch 1. Separating the two, we find what is called as the tympanic membrane, and tympanic membrane will have all the 3 germ layers. Tympanic membrane has inner epithelium which is lined by endoderm towards the middle ear cavity. It has outer epithelium towards the external auditory meatus which is lined by ectoderm. And in the middle you have the mesoderm. This mesoderm which is coming from the neural crest cell derived. So this is basically the secondary mesoderm, because as we are mentioning, in the head neck region, especially anterolateral area, mostly the mesoderm is secondary mesoderm which is derived from neural crest cells. And neural crest cells are also important because they were stimulating the endoderm to give us some pharyngeal pouch derivatives. Like pouch 1 was giving us, we mentioned, middle ear cavity and eustachian tube. So middle ear cavity and eustachian tube will be lined by some epithelium which is endoderm of pouch 1, pharyngeal pouch number 1. Now what is pouch 2 giving? The tonsillar epithelium. We already mentioned tonsil epithelium is also endoderm and derived from the pouch number 2. What about pouch 3? Pouch 3 is giving us ventrally the thymus and dorsally inferior parathyroid. Be careful about this again, because the examiner may ask, pharyngeal pouch 3, what does it form ventral? The thymus. What is dorsal? Inferior parathyroid. What about pouch number 4? Pouch number 4 will give us the superior parathyroid. Let us take some other color. Superior parathyroid. And now, in pouch number 4, there is one other structure which is developing. You have to understand that there is a pharyngeal pouch number 5 also, but it is rudimentary. And this pharyngeal pouch 5, if you say rudimentary when it was regressing, it was getting attached to the pouch number 4. And there it was forming what is called as ultimate branchial body. I'll repeat again. There is a pharyngeal pouch number 5, but it is rudimentary, it regresses. But as it was regressing, it is giving us ultimate brachial body which attaches to fourth pouch and will be receiving neural crest cells. The neural crest cells which come here to the ultimate brachial body now attaching to fourth pouch, these neural crest cells themselves will change into what is called as parafollicular C cells of thyroid and giving the C hormone which is calcitonin hormone. Pharyngeal pouch 5 remnant is called ultimate brachial body attaching to fourth pouch receiving neural crest cells. Neural crest cells themselves changing into parafollicular C cells giving the C hormone, calcitonin hormone, and calcitonin hormone is going to antagonize the parathormone which is given by parathyroid glands. So this is the basic. Among this, lot of questions will be coming to you and it is kind of a revision of course. For example, they can ask you how many germ layers are there in tympanic membrane? You say 3 germ layers. And which one? Outer ectoderm, inner endoderm, middle mesoderm. But that mesoderm is not primary mesoderm. That mesoderm is secondary mesoderm derived from neural crest cells. Sometimes neural crest cells may not reach here. Then there may be DiGeorge syndrome affecting pouch 3, pouch 4, resulting in decreased cell-mediated immunity and the hypocalcemia as well. So these are some of the facts which we wanted to know. What about the arches giving us the derivatives like muscles? Because there are questions asking which muscles develop in the first pharyngeal arch. Can you write in the chat? Let me just have a look at the chat as well. So, Lokendra, Dr. Jacob, Ashik, Iqbal, good evening. Ram Ram sir. Hi sir, yes, okay. Now, you are targeting NEET PG. Should I join the session? It will be helpful, though I am specifically targeting FMGE students, but definitely this information is going to help you even in NEET PG. So you may continue watching the session. And then we find, okay, mastication muscles. Yes, they are important actually. Right. So, as I was talking about the first pharyngeal arch derivative, the muscles, they are muscles of mastication. Let us make a table for the same and there we can revise some of the details which I believe will be helping you in the next coming exam. Here we will be putting a table showing the arch, corresponding nerve of the arch and the muscles developing. And if you talk about the first pharyngeal arch, you already have suggested they will be muscles of mastication. Not only muscles of mastication, but there are some additional muscles also which we can enumerate. But the nerve is trigeminal third division. The third division of trigeminal, that is mandibular division of trigeminal. Mandibular nerve branch of trigeminal is the nerve of first arch supplying the muscles of mastication. And in the muscles of mastication, you can remember, actually there will be total 8 muscles developing in the first pharyngeal arch. And out of those 8 muscles developing in the first pharyngeal arch, you can remember 3 elevators of the mandible, 3 depressors of the mandible. Now, if you say 3 elevators, they will be elevating the mandible so that you close the mouth. And if you say 3 depressors of the mandible, then you are opening the mouth. So, close and open the mouth using muscles of mastication. I mentioned there are 8 muscles in the first pharyngeal arch. Mostly they are muscles of mastication, like we have 3 elevators, 3 depressors, but there are 2 additional muscles which have nothing to do with mastication. And you can call them as tensors. They are 2 tensors. Their names will be tensor tympani and tensor palati, as they are going to tense the tympanic membrane and they are going to tense the palate. So tensor palati, tensor tympani will also be supplied by the mandibular nerve branch of trigeminal, though they are not the muscles of mastication, but they develop in the first pharyngeal arch. So what are the 3 elevators of the mandible which can close the mouth? You will see the mnemonic which I give here is MTM elevators, MTM elevators. Now, what is this MTM elevator? M is masseter, T is temporalis, other M is medial pterygoid. So masseter, temporalis, medial pterygoid are elevators. E is for elevator, MTM elevators. What do? They elevate the mandible and close the mouth. Can result in trismus, which came to you as a question. Trismus can be due to spasmodic contraction of trismus, which is lockjaw. Lockjaw can be due to spasmodic, spasm of muscles like masseter or medial pterygoid. So the answer which you had in a particular question which came in FMGE exam, trismus is due to spasm of, your answer was medial pterygoid. It could also be masseter, even temporalis, though preferably masseter is always a better answer. Trismus, spasmodic contraction of masseter result in lockjaw, trismus. What about the depressors, 3 depressors? We have enumerated 3 elevators, 3 depressors. The 3 depressors, which are again muscles of mastication, move the mandible down to open the mouth. Number 1 should be lateral pterygoid. And then you have anterior belly of digastric, which can move the mandible down. And there is another one, mylohyoid. So the 3 depressors of mandible are, number 1, lateral pterygoid. Number 2, anterior belly of digastric. Of course, all of them should be supplied by mandibular nerve branch of trigeminal. And mylohyoid. So 3 muscles are antagonizing the other 3 muscles. MTM are elevators. They must be antagonized by the depressors, which are here, lateral pterygoid, anterior belly of digastric, mylohyoid, all developing in first arch, supplied by mandibular nerve branch of trigeminal. What about the arch number 2? If we talk about the arch number 2, we will see that it is the facial nerve supplying the muscles of facial expression. So muscles of facial expressions like orbicularis oculi to close the eyelid, orbicularis oris to close the oral aperture. Second arch, facial nerve, muscles of facial expression, and muscles like close the eyelid, orbicularis oculi, close the mouth, orbicularis oris, smiling muscle, zygomaticus major, puffing muscle, buccinator. So buccinator or the zygomaticus major for smiling, or orbicularis oculi or oris, these are the muscles which are supplied by facial nerve. What about the third arch? If we talk about the third arch, then we will have the glossopharyngeal nerve supplying one muscle of pharynx, which is called as stylopharyngeus. It is elevator of the pharynx. So what about the third arch? As you talk about the third arch, glossopharyngeal nerve, only one muscle develops in third arch, which is important to know. Name is stylopharyngeus. Stylopharyngeus is elevator of pharynx to help us in swallowing. Elevate the pharynx, take the food down, swallowing. So stylopharyngeus supplied by 9th nerve. What about the arch number 4 and 6? I am telling arch number 4 and 6 because 5th arch is rudimentary in humans, doesn't contribute much. So what about arch number 4 and 6? Muscles and their nerves. As we continue discussing, we'll find in the table, once again we mention the arch, corresponding nerve, and the muscles developing. So arch number 4 and arch number 6, because as we are mentioning, arch number 5 is rudimentary in humans. For the arch number 4 and 6, you have branches of vagus contributing. And arch number 4, it is superior laryngeal nerve. Arch number 6, it is recurrent laryngeal nerve, branch of vagus. 10 is the number of vagus. Cranial nerve number 10, vagus. So 4th arch, superior laryngeal nerve, branch of vagus. And cranial nerve number, this arch number 6, it is vagus branch, recurrent laryngeal nerve. Which muscles develop here? You will see most of the muscles of the palate and pharynx. Muscles of palate and pharynx, they develop in 4th arch, whereas muscles of larynx, they develop in the 6th arch, with a few exceptions. So what are the exceptions? We have just mentioned tensor palatii do not develop in 4th arch because tensor palatii was developing in the first pharyngeal arch, supplied by mandibular nerve, branch of trigeminal, if you remember. So most of the muscles of palate and pharynx will develop in the fourth arch, but there are some exceptions. Most of the muscles of palate develop in fourth arch, except stylopharyngeus developing in third arch, supplied by glossopharyngeal nerve. All are MCQs. What about the larynx muscles? Most of the larynx muscle develop in the sixth arch, supplied by recurrent laryngeal nerve, except, and that except is basically a tensor of the vocal cord, cricothyroid muscle. So where is cricothyroid muscle developing? Cricothyroid muscle is a muscle of larynx, but do not develop in sixth arch. Then where is it developing? It develops in the fourth arch. And because the cricothyroid muscle, which is the tensor of the vocal cord, develops in the fourth arch, it is supplied by a branch of superior laryngeal nerve. So which branch of superior laryngeal nerve? It is called as external laryngeal nerve. What will happen if external laryngeal nerve is damaged during thyroid operation? During thyroid operation, you might be damaging external laryngeal nerve, branch of superior laryngeal nerve. Which muscle will be compromised? Cricothyroid muscle. So what will happen to the patient? The pitch of the voice will be compromised, because cricothyroid muscle is a tensor of vocal cord. It increases the pitch of the voice. A singer must have high pitch, control over his high pitch. There was a singer, you operated for thyroid gland. By mistake, you have compromised external laryngeal nerve, which can happen. Then the singer can sing no more as competitively as he was earlier doing, because you have compromised the tension of the vocal cord, and cricothyroid muscle is paralyzed in that case. So these are all MCQs. Okay, so this is about the pharyngeal arches, basically pharyngeal arch muscles. But then you should know, pharyngeal arch muscles are not from neural crest cells. Though I mentioned in the pharyngeal arches, most of the mesoderm is from neural crest cell, secondary mesoderm, but not these muscles. These muscles, if you are talking about the pharyngeal arch muscles, they are not from neural crest cells. They are not from secondary mesoderm. They are from the primary mesoderm. So these muscles are from primary mesoderm. Why? Because remember this quite significant information, neural crest cells do not form skeletal muscles. Neural crest cells do not form skeletal muscles. And these are all skeletal muscles. So if these skeletal muscles are not formed by neural crest cell derived secondary mesoderm, then where would they come from? They would have come from primary mesoderm. Just to be aware of all these facts. Okay, so we go back, and this was our discussion on the pharyngeal pouches. One thing which you can now add finally is, at the floor of the pharynx, which is lined by endoderm, at the floor of the pharynx, which is lined by endoderm, you will find that there is a foramen cecum, and that foramen cecum is developing in the tongue, because tongue also develops at the floor of the pharynx. So foramen cecum, which is developing in the tongue, which itself is developing in the pharynx, from there some endoderm goes down and reaches here to form the thyroid gland. Thyroid gland is endodermal in origin, and it is the endoderm which is kind of migrating from the tongue, foramen cecum, to the neck region, and that is how we can mention endoderm of the foramen cecum region in the developing tongue forms the thyroid gland. What about the parathyroid gland? Even parathyroid glands are endodermal in origin, but from the lateral wall. The inferior parathyroid is, as we said, PP3 tip. Inferior parathyroid from the third pharyngeal pouch, and superior parathyroid from the fourth pharyngeal pouch. That's all we wanted to talk about in this region. And as we move further, now this is one of the topic which is persistently asked to you. Termination of the spinal cord, maybe in the newborn baby, in the adults. Okay, so let me just go through the chat. Shots wife, Jai Hind sir, Jai Hind, yes. We are also soldiers of our country. Our front is different. We are not standing there at the borders, but still we are standing at some borders. Okay, Chico, Crico third. Right. Okay, so we continue. Now here what I want to focus upon is, in the beginning, when you look at the developing fetus, you will find the length of the spinal cord is equal to length of the vertebral column. In here, the early fetal stage, as you notice, 9-week fetus, these blue dots are basically the vertebra in the vertebral column, and the length of vertebral column is shown same as the length of the spinal cord, which is shown anterior to the vertebral column here in this diagram. The spinal cord is also attached to the terminal bones, which are coccyx bone in the vertebral column in the beginning. So not only spinal cord has equal length as the vertebral column, but it is fused to the bone coccyx. But later there is differential growth. The length of vertebral column keep increasing, as much that in the adult you will find the vertebral column is actually 60 centimeter long, 60 centimeter, whereas the spinal cord is only 45 centimeter long, shorter. Now maybe spinal cord is shorter in the adult and vertebral column is longer, but the initial attachment of the spinal cord to the coccyx is persisting. So that attachment which is persisting, which you can show here, attaching to the tip of the spinal cord and the coccyx, is actually a fibrous tissue which is called as phylum terminale. Maybe the spinal cord is terminating at a higher level than the coccyx, but the attachment continue to persist as phylum terminale, which is some collagen fiber, fibrous tissue. And this is again the tip of the spinal cord attaching to the bone coccyx with the help of phylum terminale. Some books will say it is a modification of pyometer. What I say is, phylum terminale is some collagen fibers covered by pyometer. Normally pyometer is covering the spinal cord, but it will continue down to cover the phylum terminale and eventually reach the bone coccyx. So where is spinal cord terminating? In the adult. In the adult, the spinal cord is terminating, as you can see here, lower border of L1 vertebra, which is also called as transpyloric plane, because that is where you have the pylorus of stomach becoming the duodenum. So where the pylorus of stomach become the duodenum, that is the L1 vertebra lower border in adult. And the same point, transpyloric plane, you will see termination of adult spinal cord. So is it the termination of pyometer also? No. Though the pyometer is covering the spinal cord very much closely, should stop at L1 only, doesn't. What it does is, it will continue downward covering the phylum terminale and eventually fuse with the bone coccyx. So pyometer stops at the bone coccyx. Now this is for the adult. What about the newborn baby? When a baby was born, the spinal cord was still comparatively going higher and higher. So this becomes a controversy, because some books will say if it is a newborn baby, the spinal cord is terminating at L3 vertebra upper border, and some will say L2 vertebra lower border. Now if it is L3 vertebra, or some will say L2-3. Now that is not the end of controversy. There are some books which will say it is terminating at the lower border of L3 vertebra. That is definitely a controversy. So what should I choose? In a newborn baby, where is the termination of spinal cord? I have 3 answers in 3 different standard textbooks. I'll prefer what you see in this diagram also, like let me rub it and you will find. What you should remember is, it is the L3 vertebra upper border. That is the best answer. Now if L3 vertebra upper border is not in the option, then you may choose, you may follow Vishram Singh anatomy, which says L3 lower border. So this is your second answer, this is your first answer. And if both of them are missing, then you may tell, like some other books, it is the disc between L2 and L3. L2 and L3, but that will be your third answer in sequence. The first answer is always L3 vertebra upper border, not found. L3 vertebra lower border, not found. Then you may say disc between L2 and L3 vertebra. Now, why I am so specific about this particular question? Because the examiner keep changing the options. So remember the best possible option, L3 vertebra upper border. That should be what you should be looking for. If not found, then you might change your answers according to the available options. Now, we mentioned that in an adult, the spinal cord is terminating at L1 vertebra lower border, which is transpyloric plane. Pylorus of stomach is also there. What about the pia mater? Pia mater do not stop there, it reaches till the bone coccyx. What about the next membrane, which is arachnoid mater? If you talk about the next membrane, which is arachnoid mater, let us show it here. Arachnoid mater continues a bit down, and it will be reaching till the S2 vertebra lower border. And as the arachnoid mater reaches till the S2 vertebra lower border, under that there is a space, subarachnoid space, and that subarachnoid space is also ending at the same level, which is S2 vertebra lower border. So at S2 vertebra lower border, what else? What are the two things which are stopping? Number one, the arachnoid mater, the meninges, and number two, the subarachnoid space. Now this space, which is filled with CSF, is called as lumbar cistern. We call it as lumbar cistern, and that is where you can put a needle and aspirate CSF. A question comes when you are doing lumbar puncture to aspirate the CSF, where will you be putting your needle? And that again is a controversy, that where should you put your needle to aspirate the CSF. Let us make a diagram to discuss the same story once again. As we talk about this all, remember the important landmarks. Let me take some open space here. So you should remember some of the landmarks, like one of the landmark is L1 vertebra lower border. L1 vertebra lower border. And what is the other landmark? It is S2 vertebra and lower border. So what are they representing? We mentioned that there is this termination of spinal cord here. Spinal cord is terminating at the L1 vertebra lower border, which is also called as transpyloric plane. But the attachment, which is called filum terminale, do not stop here. The filum terminale, which you can show here, was coming here and attaching to the bone coccyx down here. So maybe the spinal cord terminate at L1 lower border, but the filum terminale, which is some collagen fiber, fibrous tissue, and covered by pia mater, is reaching till the bone coccyx. Now, pia mater, which is covering the spinal cord, is reaching the coccyx. What about the next meninges, which we talked about, the arachnoid mater? If you are talking about the arachnoid mater do not stop at this L1 lower border. It continues down and it reaches till the S2 vertebra lower border. And deep to that is this space, subarachnoid space, which is filled with CSF, and we are calling that space filled with CSF below spinal cord as lumbar cistern. And in the lumbar cistern, we wanted to put a needle and we wanted to aspirate the CSF. So if I am putting a needle in the lumbar cistern to aspirate the CSF or give some lumbar puncture anesthesia, my needle should be going in between which vertebra? That is one question. So this is arachnoid mater, this is the subarachnoid space, and subarachnoid space is filled with CSF. You want to aspirate the CSF. And the other thing which you mentioned is the arachnoid mater and the subarachnoid space, both of them are terminating at S2 vertebra lower border. And that is where we are putting this needle. The answer to your question is L3 and L4 vertebra. So your needle should be going between L3 and L4 vertebra, though be careful that you can push this needle even between L4 and L5 vertebra. You can push this needle between L4 and L5 vertebra also. That is also equally good. But preferably, if a question comes, your needle should go between L3-4, first answer, not found in the option, change it to L4-5, second answer in, you should always be ready with your second answer, if first is not available. Okay, now the next question which they ask is, you are going to puncture some of these structures when you push a needle for lumbar puncture. Which structures you are going to puncture? Obviously, the very first thing is skin, and after skin, superficial fascia, and after that, some ligaments. So, which ligaments? That comes as a question, and I have got a diagram for that. It is here. So, which ligaments are you going to puncture when you are doing the lumbar puncture, aspirate CSF or inject your anesthesia, LP? You are in the lumbar vertebra region. So, lumbar vertebra will have a body and it is having a spine, a lamina, the pedicle in a transverse view and in a sagittal view. Sagittal means anterior to posterior, you have taken a section. So, where is our needle? Say our needle is going this way. Let us take some color which is evident to us, maybe a darker color. Our needle is going this way. And between which vertebra? That is the upper L3 vertebra, the lower L4 vertebra. This is the body of vertebra anterior, this is the spine of vertebra posterior. This is the body of vertebra, spine of vertebra. So, as you are pushing your needle, what is the first thing you puncture? The skin, and after that, superficial fascia or subcutaneous tissue. So, skin, superficial fascia, and after that 3 ligaments. And which ligaments? The ligaments are connecting the spine with each other. So, we will call them as supraspinous ligament. First ligament, which is shown in yellow color, supraspinous ligament. And after that, shown in green color is the interspinous ligament. Because it is between the spines, interspinous ligament. And after that, connecting the upper lamina and lower lamina, because it is upper vertebra, lower vertebra, there have lamina. Connecting the lamina, blue color, is ligamentum flavum. So, I will puncture ligamentum flavum. Now, once you have punctured skin, subcutaneous tissue, supraspinous, interspinous and ligamentum flavum, where do you reach? I reach the vertebral canal where you have the lumbar cistern. I want to puncture and remove the CSF. But before you reach the CSF space, what should you puncture? After puncturing these ligaments, I have to puncture some meninges. Like which meninges? As you understand, the spinal cord is adherently covered by pia mater. And do you find spinal cord at this level where you are doing puncture? No, you don't find spinal cord. But from the spinal cord, there are some nerve roots coming, anterior, posterior nerve roots called as cauda equina. So, that cauda equina, instead of spinal cord, you will have what is called as cauda equina covered by pia mater. So, no spinal cord in lumbar cistern, but cauda equina, the nerve roots coming from terminal spinal cord, they will be found. Now, they are covered by pia mater. What is pia mater themselves itself covered by? Pia mater itself will be covered by the arachnoid mater, and deep to arachnoid mater I want to go because that is why we have the CSF. But still, outside the arachnoid mater, what do you have? Outside the arachnoid mater, I will have what is called as the dura mater, because that is the last meninges we have got. Point is, when your needle was going here, passing supraspinous, interspinous, ligamentum flavum, you have to puncture 2 meninges now to reach the subarachnoid space. And which meninges they are? The dura mater and the arachnoid mater. Obviously, you are not going to reach the cauda equina area, but the thing is that you must be in the subarachnoid space. So, number 1, you have to puncture dura mater. Number 2, you have to puncture arachnoid mater. And obviously, you cannot puncture the pia mater because pia mater is very much adherently enclosing the nerve roots. And you are not supposed to, even if you reach the nerve roots, they will just move here and there in the subarachnoid space. So the two meninges which you puncture are dura and arachnoid mater. That is the sequence which you should remember. What if I am doing epidural anesthesia? If you are doing epidural anesthesia, then you might puncture the skin, superficial fascia, the three ligaments, that is supraspinous, interspinous, ligamentum flavum, but then you don't puncture any meninges because you are doing what is called as epidural anesthesia. Epidural means outside dura mater. So you will have some fat here, and in that fat you can put your bupivacaine or whatever anesthesia agent you are using in epidural space. No meninges to be punctured if it was epidural anesthesia. So epidural anesthesia, which is the last structure you puncture, is a question. For epidural anesthesia, the last structure I puncture will be the ligamentum flavum. Next question, what is the last structure you puncture for lumbar puncture anesthesia? In that case, the last structure I puncture is arachnoid mater, because after puncturing arachnoid mater, I can reach the subarachnoid space and inject my lignocaine or whichever anesthesia agent you are using. So last structure to be punctured is coming as a question. Now, let me just go through the chat if you have any queries. Okay. Right, you have mentioned all the ligaments, but my point was that the questions are coming like this. If you are doing epidural anesthesia, what is the last structure you puncture? Your answer is ligamentum flavum. And if you are doing lumbar puncture anesthesia, then what is the last structure you puncture? Then your answer will be arachnoid mater. Just be aware of that. Okay, work hard from Pakistan. Yes, of course. I agree with that. We have to work hard. We are clinicians, and people's lives are in our hands. They should not be, we should work 100%, whatever capacity we have got. And working hard is always giving you back some rewards. Okay, popping sensation. There's a question on popping sensation, that's what you're asking. English please. इंग्लिश में तो मैं पढ़ा हूँ, लेकिन कल मैं चैट के थ्रू जा रहा था तो कुछ बच्चों ने लिखा कि सर हमें तो इंग्लिश आती नहीं, हम तो इंग्लिश ही जानते हैं, तो इसलिए मैं इंग्लिश यूजुअली अवॉइड करता हूँ, नहीं इस्तेमाल करता। इन सेशंस में जो ऐप है, ऐप में तो इंग्लिश है ही और इंग्लिश भी है, पर इन सेशंस में कोशिश करता हूँ कि इंग्लिश में ही बोला जाए। Popping sensation. When you are an anesthetist, you are using a needle, lumbar puncture needle, you are pushing through supraspinous, interspinous ligament and the ligamentum flavum. There is a resistance to your needle. Because you are passing through ligaments, there will be resistance. Sudden loss of resistance is felt when you are eventually puncturing ligamentum flavum. That is called as popping sound. So as your needle passes through interspinous, the supraspinous, interspinous and ligamentum flavum, you had a resistance to your movement of the needle, and suddenly there is a sudden loss of resistance because you have punctured all the ligaments, and there will be a popping sound felt. You feel it, sudden loss of resistance. That is called popping sound 1. And you can do epidural anesthesia. But if you want to give lumbar puncture anesthesia, you continue pushing your needle, because you have to puncture now dura mater and arachnoid mater also. There is a second popping sound. What is that second popping sound due to? First popping sound is when you have punctured the ligamentum flavum. Now you are puncturing dura mater and there will be a resistance for the movement of your needle. So as you try to puncture dura mater, there is a resistance. As you puncture dura mater, that resistance is lost again. Sudden loss of resistance after you puncture the dura mater. That is called second popping sound. Now the problem is, examiner is asking, popping sound is felt due to puncture of. You will have double answer. Puncture of ligamentum flavum and puncture of dura mater. But he is asking, no, give me only one answer. Then what should you choose? If popping sound is coming because of puncture of ligamentum flavum as well as puncture of dura mater, and both options are there. Which one should I choose? My advice is you should choose for ligamentum flavum, the first popping sound in preference. And in the options, if I do not find ligamentum flavum puncture, then you can choose the second answer. The popping sensation can also be felt due to puncture of dura mater. But in popping sensation, first answer should always be ligamentum flavum and second answer could be the dura mater puncture. I hope you got my point, and now we move further. So, how do we know, sir? I mean, what is the indication that we are in the right place? Your training, your experience, that popping sensation which you feel, resistance, sudden loss of resistance, and the needle also, the length of the needle, the length of the needle, there are markings which you can use, and this much is required to reach this particular space, and more of it is more of your experience, and you can use ultrasonography also, ultrasound guided. Okay, then we are moving on to the next topic here, which is important for your preparation towards your next coming FMGE exam. These kind of questions are coming nowadays. There is a patient in supine posture, head is away from you, feet are towards you, you are having an inferior to superior view, and what they have done is taken a CT scan. So CT scans are usually viewed inferior to superior. This will be the right side of the patient, that will be the left side of the patient. Not only the CT scan, but also they give you dissected specimen, and even those dissected specimens should be viewed as if you are looking from inferior to superior. That is better as a convention. So they gave you one diagram, and it was a dissected specimen. Next time they gave you one radiograph and asking A, B, C, D. Identify these structures. Now this is thorax region, and this is the level where you are taking the section. Let me zoom this a little bit. This section, as is also mentioned here in this diagram, T5 vertebra level, thoracic 5. Actually at the T5 level you are taking a section where you will find some of the vessels. We understand superior vena cava, inferior vena cava enters the right atrium. So superior vena cava is the large vessel to the right side. The most right-sided structure, a large vessel, is superior vena cava. Inferior vena cava come from below, but we have taken a section at T5 level, so superior vena cava. What is the next vessel which you will find? It will be the ascending aorta, left ventricle giving ascending aorta. It is seen next. So superior vena cava, ascending aorta. What is still next towards the left side? So number one, we are telling it is superior vena cava. Number two, we are telling it is ascending aorta. What is the next thing which you find? And it is shown in blue color. That is the right ventricle sending pulmonary trunk. Right ventricle sending pulmonary trunk. Why you are showing the pulmonary trunk in blue color? Because it is carrying deoxygenated blood. Pulmonary trunk carries the deoxygenated blood. That is why blue color. It is taking it to the lungs so that lungs can oxygenate it. So blue, red and blue. Yes, blue, the first blue to the right side is superior vena cava. It brings the deoxygenated blood of the body, upper body, into right atrium. And what is this red color? The ascending aorta, which is bringing oxygenated blood from left ventricle, pushing it throughout the body. So ascending aorta. What is this other blue vessel? That is the right ventricle sending the pulmonary trunk. You need to have the respective orientation of these three large vessels. Plus you should know this ascending aorta will take an arch of aorta and go down as descending thoracic aorta. So basically when you have taken a section, you will find not only ascending aorta but also descending thoracic aorta. Though ascending aorta will be more anterior and descending aorta will be more posterior. This is more relevant when you look at this transverse section. So, at a particular moment you may find ascending and descending aorta. Ascending will be more anterior in relation with one vein here, one vein here. It is not exactly vein, means deoxygenated blood vessels, and one vessel, thoracic aorta, will be posterior. That same story you can use here. First of all, which vertebra level is that? T5 vertebra. So first you locate the vertebra. This is T5 vertebra, transverse process on either side, and this is the spine of the vertebra posterior. Now, if that is the T5 vertebra, body and transverse process and spine, what is this black color here? That black color is nothing but a vertebral canal where you will find the spinal cord is protected. Now, this is the vertebra posterior. What is this structure here attaching with the vertebra on this side as well as that side? That is the rib. We have learnt the costal vertebral joint, plain synovial joint, freely mobile joint. So, ribs articulating with the thoracic vertebra and making plain synovial joint, which are freely mobile joint. This is a marking of rib, this is a marking of rib, this is a marking of rib. What is this structure anteriorly on the anterior thoracic wall? Posterior thoracic wall, you have the vertebra, but what is on the anterior thoracic wall? Anterior thoracic wall, you will have the sternum. And if that is the sternum in the anterior thoracic wall, what is in the mediastinum? Because this is dark black color is representing the lung, because inferior to superior, this must be the right lung. Here you can mention this is right lung, and this must be the left lung, because inferior to superior, right lung, left lung. What is between the two is mediastinum. In the mediastinum, you can have the heart and corresponding blood vessels. Plus, if you are in the posterior mediastinum, in the posterior mediastinum, you can have the esophagus and trachea. So, in the posterior mediastinum, specifically the esophagus. Esophagus is identified by the fact that it is immediately lying over the vertebra, thoracic vertebra. Just anterior to the body of thoracic vertebra, the lumen, if you see, must belong to esophagus. Let me zoom it if it is possible a little bit more, but not possible. So, this much is okay. Now, if you say this is the region of the esophagus, just lying on the vertebral body, what is in front of that? In front of that will be the trachea, and as you see, let me use some color which is evident here. This is tracheal bifurcation, the carina. Carina is at the level of tracheal bifurcation and showing the right principal bronchus and the left principal bronchus. So, trachea has already divided because it is T5 vertebra. Normally, the bifurcation of trachea is at disc between T4, T5 vertebra. So, already you are at T5, it has bifurcated. Carina is at the bifurcation and right principal bronchus sending air into right lung and left principal bronchus sending air into the left lung. Now, if that is esophagus, this is the trachea, what is in front of that? Here you can see one vessel which I can use some color which is different from all these colors. This is right ventricle sending the pulmonary trunk dividing into two pulmonary arteries. So, right ventricle sending the main pulmonary trunk which is dividing into two vessels, the right pulmonary artery to the right lung and left pulmonary artery to the left lung. It is the deoxygenated blood from the right ventricle going to the right lung and left lung, which can then get oxygenated. So, where is this pulmonary trunk bifurcating? Again, it is also the same level where you find tracheal bifurcation between vertebra T4 and T5. That is where it happens. Trachea bifurcates into two, pulmonary trunk is dividing into two, right pulmonary artery, left pulmonary artery. The other thing which you find here is, if that is the pulmonary artery, what will be on the right side of that? and still on the right side of that. If that is the pulmonary artery, on the right side of that will be ascending aorta, and still on the right side will be superior vena cava. So what you find is, again, this is pulmonary trunk and the vessel, which, let us use this color, here is ascending aorta. If that is ascending aorta, what is still to the right side of that? Still to the right side of that, we can use some other color, this one, that is superior vena cava. So the three vessel arrangement, pulmonary trunk, ascending aorta and superior vena cava. Pulmonary trunk, ascending aorta, superior vena cava. That arrangement, if you know from the front view, can be seen in a transverse section also. Now if that is ascending aorta, which is more anterior, where is descending thoracic aorta? It will be more posterior, and here, this is descending thoracic aorta. How do you know that this is descending thoracic aorta? First of all, as compared with these vessels, it is more posterior, related to the vertebra and to the left side of the midline. To the left side of midline, lying on the vertebra. So a vessel which is lying on the vertebra but to the left side is descending thoracic aorta. Almost in the midline will be esophagus. In front of that will be the trachea, and to the left side, to the midline, on the thoracic vertebra will be descending thoracic aorta. So that is ascending aorta, this is descending thoracic aorta. And with that view, if you were given a dissected specimen also, you could have found it. This was the arrow. This was the arrow given to you, FMGE question only, asking you what is this arrow mark, and choices are esophagus, trachea, aorta, pulmonary trunk, like that. So what do you think? Now let us carry out the process which we earlier have done. Again, what is posterior here? This is the body of the vertebra. What is this? The spine. Here, the transverse process, two transverse spine. Where is spinal cord? This is the spinal cord in the vertebral canal. What is this structure which will be lying? Let me take some other color. Structure which is lying just anterior to the body of the vertebra, esophagus. What is still in front of this is basically esophagus. This is the esophagus. Let me rub it off and draw it again. This is the body of the vertebra, just lying anterior to the body of vertebra will be esophagus. If you see, this is the lumen, that is the esophagus. If that is the esophagus lying in front of the body of the vertebra, what is to the left side of that? To the left side of that, as is evident, is descending thoracic aorta. If that is descending thoracic aorta, where is ascending aorta? Ascending aorta will be sandwiched. And if ascending aorta is sandwiched, it is sandwiched between which two vessels which are carrying deoxygenated blood? The ascending aorta is sandwiched between pulmonary trunk and the superior vena cava. Now, if that is superior vena cava, it is to the right side. If pulmonary trunk, it is to the left side, sandwiching the ascending aorta. What is pulmonary trunk doing here? Pulmonary trunk here is giving us the right pulmonary artery to the right lung, shown here, this is right lung, and left pulmonary artery giving the deoxygenated blood to the left lung. Bifurcation of the pulmonary trunk. Which vertebra level? Disc between T4, T5 vertebra. And if this is the pulmonary trunk, what is these two open spaces in front of the esophagus? In front of esophagus, but behind pulmonary trunk, as you are marking, let us take some other color, maybe white only. This is the right principal bronchus, that is the left principal bronchus. So what are the arrangement of structure posterior to anterior? Body of vertebra in front of that, esophagus in front of that, tracheal bifurcation into right and left pulmonary bronchus in front of that, pulmonary trunk. A question came, it was asking, what is the arrangement of the structures which enter or leave the lung hilum, anterior to posterior? You will see the most anterior structure which enter or leave the hilum of lung. will be, as we can use some other color, pulmonary vein. Pulmonary vein is most anterior. Behind that is pulmonary artery. Behind that is the bronchus. The arrangement will be VAB, anterior to posterior. V is the vein, pulmonary vein. A is the artery, pulmonary artery. And B is the bronchus. Like here it is left principal bronchus. Anterior to posterior, arrangement of the structure, entering or leaving the hilum of lung. Now you can imagine why the vein is more superficial, because it has a thin wall, it may be collapsed if you keep it more posterior. And what is in the middle? The artery. It has thick wall. Which one has the thickest wall? The bronchus. Bronchus is thickest wall, so kept most posterior. VAB, anterior to posterior. This is also coming as a question. So what we have done here is making us comfortable with even a dissected specimen and looking for the structures which might be found in a transverse section of the thorax. Okay, now as we move further, let me just look at the chat. If you have any queries, VAB, very fine. Okay. Karina at bifurcation, right. Yeah, fine. I believe you all are quite well versed with the details which I am giving, and it is just appearing like a revision only, because what I find is most of you have been quite aware of the details which I am giving here. What about abdominal transverse section? See, if it is abdominal transverse section, you won't see the lungs there, because lungs are above the diaphragm. Above the diaphragm you will see the lungs, so thoracic. If you are below the diaphragm, it will be abdomen, and you might see liver and spleen. Like yesterday we have seen a transverse section. It was below the diaphragm, it was in the abdomen, and there you will find the liver and spleen and pancreas and all that. And of course, a transverse section in the abdomen may also come to you as a question. It can. But at the moment we were focusing upon thorax region. Before we move on to abdomen region, let us pass through the upper limb region as well, because normally what I do is I teach this way: neuroanatomy, head and neck, then it will be the thorax region, back region, upper limb, and then you will go below diaphragm, that is to the abdomen region. Maybe tomorrow we will be taking care of abdomen region, pelvis, perineum and lower limb, but today we have to finish till the upper limb region, upper body basically, above the diaphragm. So in the upper limb, there are several questions which are coming. Before we focus on this area, there is a question it was asking you. It's quite a frequently asked question actually. Where is fracture of clavicle happening? And most of us know that if we talk about the fracture of clavicle, say this is the clavicle region here, this is the clavicle here, this is the right clavicle here. I have magnified it slightly. Clavicle can be divided into three parts: the medial 1/3, middle 1/3 and lateral 1/3. So I'll write here three parts basically: the medial 1/3, the middle 1/3, and then we have got lateral 1/3. Now it is not a very big deal, but examiner can confuse you asking about the fracture of clavicle. The best possible way of answering is the fracture actually happens here. Where? At this point. What is this point? This point where you have the junction of middle 1/3 and lateral 1/3. So the best possible answer which you can give for fracture clavicle, the most common site of fracture clavicle, you should write at the junction of middle 1/3 and lateral 1/3. Now what if that is not in the option? Then you can also say it is the junction of medial 2/3 and lateral 1/3. So this is another way of answering the question. You can say it is a junction of lateral 1/3, which is same as here, but medial 2/3. So you can write here as medial 2/3. Point is, if they are asking for most common site of clavicle fracture, the best answer would be junction of middle 1/3 and lateral 1/3. Middle 1/3 and lateral 1/3 if not found, then go for medial 2/3 and lateral 1/3. Now why I am so much specifying upon this is because there can be questions having both the options together. If both options are together, this is your first answer. Middle 1/3 is preferable to medial 2/3. Just for the sake of clarity. It is not very logical, but we always train you according to the type of questions which are coming and making you avoid controversies, making you avoid answering wrong. Okay, one more question which came is, let me just rub it off everything here. It was actually asking you about the elbow joint level, and at the elbow joint they are asking something like, you see, may not be very high magnification possible here, but I will draw it myself. Say they were asking about the condyles of the humerus. Say this is left elbow joint now, lower end of left humerus. So when you look at the lower end of the left humerus, you'll find there is a lateral condyle and there is a medial condyle. This is the lateral condyle and this is the medial condyle. The name of lateral condyle is called as capitulum, and the name of the medial condyle is called as trochlea. So they are putting some of the markers on lateral condyle and medial condyle. How do you identify them if it is given to you in X-ray? You will see that these are condyles at the lower end of the humerus. Above them there are epicondyles, and medial epicondyle is larger than the lateral epicondyle. If you look at this bony projection, there is a bony projection which is called medial condyle, you see here, and there is a projection which is called lateral epicondyle. So medial epicondyle is quite larger as compared with lateral epicondyle. Then came a question. Medial epicondyle, anteriorly, the flexor muscles are taking origin, flexor muscles of the anterior forearm, and it is called as common flexor origin. So medial epicondyle is called as common flexor origin because here a lot of flexor muscles are taking origin. Anterior surface of medial epicondyle, you see a lot of flexor muscles taking origin. For example, pronator teres. Pronator teres muscle taking origin. Common flexor origin. Similarly, lateral epicondyle, anterior surface only. Lateral epicondyle, anterior surface only is called as common extensor origin because from the lateral epicondyle, anterior surface only, lower end of humerus, you have muscles taking origin in the posterior forearm muscles, which are extensor muscles. So common extensor origin. That is common extensor origin giving us the extensor muscles like extensor digitorum. You want to extend the digits? Extensor digitorum muscle takes origin from there. If there is a tennis player, common extensor origin can be inflamed, tennis elbow. If you are talking about the tennis elbow, you will have inflammation in the lateral epicondyle. It is called lateral epicondylitis. Lateral epicondylitis. Pulling on the muscles of posterior forearm, extensor muscles, common extensor origin. Is tennis elbow? If it is a golfer's elbow, then medial epicondylitis. So medial epicondylitis, the golfer's elbow, These are some of the questions which you might get, actually are getting very frequently. So golfer's elbow is itis, medial epicondyle itis, pull at the common flexor origin, the area from where flexor muscles were taking origin. So just making it sure that if you get questions around the elbow joint, you should be able to handle them properly. And then coming to this particular question which we wanted to focus upon, they can ask you some of the nerves coming from brachial plexus and related to bone humerus. This time it is right humerus here. Now this is the right humerus, and some of the nerves which are related to the humerus might be damaged. Say for example, there is a fracture surgical neck of humerus, fracture mid-shaft humerus, fracture lower end of humerus, supracondylar fracture. If that kind of fracture happens, then which nerves are prone to injury? First of all, you should know that there is a lower trunk of brachial plexus in the neck region. Lower trunk of brachial plexus in the neck region. And let me zoom it a little bit. This is the, let us make use of this color, lower trunk of brachial plexus in the neck region. Now this is the lower trunk. As it passes behind the bone clavicle, enter the axilla. It will continue as medial cord of brachial plexus. So first of all you say it is lower trunk of brachial plexus, now it is medial cord of brachial plexus. Root value? Root value is C8 and T1, which is the root value of hand muscles also, especially lumbrical interossei. They are supplied by lower trunk of brachial plexus, which continues as medial cord of brachial plexus, which then continue as the ulnar nerve. So medial cord of brachial plexus will continue downward as the ulnar nerve going towards the ulnar bone, which we can zoom and see. What is the root value of ulnar nerve then? The same as the medial cord or the lower trunk, which is C8T1. So C8T1 root of brachial plexus continuing as lower trunk of brachial plexus, then medial cord of brachial plexus, then ulnar nerve. What will happen if there is a clump case palsy? Clump case palsy is a problem of lower trunk of brachial plexus. It is pulled and ulnar nerve can be compromised. Most of the hand muscles, their root value is C8T1, are actually supplied by ulnar nerve. So most of the hand muscles are supplied by ulnar nerve, they will be compromised, leading to claw hand deformity. Why there is claw hand deformity? Due to paralysis of hand muscles supplied by root value C8T1. And which muscles are you talking about? They are the muscles called as lumbrical and interossei, intrinsic muscles of the hand. So injury of lower trunk brachial plexus, root value C8T1, compromise ulnar nerve, and the paralysis of lumbrical interossei leading to claw hand deformity. Where will be the sensory loss? Sensory loss will be in the same dermatome, C8T1. And where is C8T1 dermatome? Little finger and medial side of elbow. Little finger and medial side of elbow, because that is where the ulnar nerve is going, medial side of elbow. So little finger dermatome and medial side of elbow, that is C8 and T1 dermatome, sensory loss in clump case palsy. Let me zoom this out now and you will see this is the ulnar nerve we are talking about. As we continue it downward, you find that this is the ulnar nerve passing behind medial epicondyle. And because ulnar nerve passes behind medial epicondyle, it is not on the right side we are looking at, it is not a content of cubital fossa, the space in front of elbow joint. There is a space in front of elbow joint which is called as cubital fossa. Which nerve is not a content of cubital fossa? Ulnar nerve. Why ulnar nerve is not a content of cubital fossa? Because cubital fossa is in front of elbow joint, but the nerve is passing behind the medial epicondyle. So it is not a content of cubital fossa. And then it runs with the bone ulna. This is the medial bone, medial cord, medial nerve, medial bone, ulnar nerve. Okay, what about the posterior cord of brachial plexus? If you look at the brachial plexus in the axilla, you will find there is a posterior cord of brachial plexus also. This is posterior cord. The posterior cord of brachial plexus will continue as radial nerve, passing in the radial groove behind the mid shaft of the bone humerus, and then coming in front of the lateral epicondyle, becoming a content of cubital fossa there. So radial nerve is definitely a content of cubital fossa, but where is it coming from? Once again, as you see in the right axilla, you are looking at posterior cord of brachial plexus. Posterior cord of brachial plexus in the right axilla, continuing as radial nerve in the radial groove, and this radial nerve, when it is passing in the radial groove, it is posterior to the bone humerus, mid shaft humerus. If there is a fracture, mid shaft humerus, the radial nerve can be damaged in the radial groove. And if the radial nerve is damaged in the radial groove, it is the nerve which supply extensor muscles, nerve of extension. Extensors will be compromised, leading to loss of wrist extension, what is called as wrist drop. So I have got a case where there is a fracture mid shaft humerus and radial nerve injury in radial groove, which is behind the mid shaft of bone humerus. Since radial nerve is the nerve of extension supplying extensor muscles, they are paralyzed. You cannot do wrist extension and there will be a wrist drop. The posterior cord of brachial plexus give one more important branch in the axilla, and which you can follow here, is going around the surgical neck of humerus. Surgical neck of humerus, and that nerve is axillary nerve. So here you have seen two branches from the posterior cord of brachial plexus. One, the radial nerve, the other is axillary nerve. What will happen if there is a fracture, surgical neck of humerus? If there is a fracture of the surgical neck of humerus, the nerve damage is the axillary nerve coming from posterior cord of brachial plexus. So what will be the problem? Problem is it supply two muscles, they will be compromised. Which two muscle it is supplying? A powerful abductor at the shoulder joint, the deltoid, and a lateral rotator at shoulder joint, which is teres minor. So if there is a fracture, surgical neck of humerus, axillary nerve is damaged, there will be a problem of shoulder abduction because the deltoid is paralyzed, and problem of lateral rotation at the shoulder joint because teres minor is a lateral rotator supplied by axillary nerve. Where will be the sensory loss? Sensory loss will be on the skin covering the deltoid, but lower part of deltoid, C5 dermatome, C5 dermatome. So these are all questions. It is also called as regimental batch anesthesia. What is the problem? Problem is surgical neck fracture of humerus. So what happened? Axillary nerve damage. So what happened? Problem of shoulder abduction and lateral rotation and sensory loss. Where? Regimental batch anesthesia. What is that? There is sensory loss on the skin covering lower half of deltoid. Why not upper half? Because upper half is C4 dermatome, it is a different nerve, it is called as supraclavicle nerve, it is still working. So skin on the upper half of the deltoid. Skin on the upper half of deltoid is C4 dermatome, it is supplied by supraclavicle nerve, it is still working. Problem is with C5, which is skin on the lower half of deltoid. That is where you must have observed army people, police people, navy people keep a batch, regimental batch. I belong to Navy regiment, regimental batch anesthesia, sensory loss below that area. C5 dermatome. Regimental batch anesthesia is a problem of axillary nerve injury, C5 dermatome. Okay, what about the median nerve? Median nerve, if you want to focus upon then you will find in the axilla there are 3 chords: medial chord, posterior chord, and lateral chord. Let us look at the lateral chord also. And as you talk about the lateral chord, this is the lateral chord of brachial plexus, which will then continue as a nerve called as musculocutaneous nerve. So if we talk about the, let me choose the blue color only, that will be better. Musculocutaneous nerve is continuation of lateral chord of brachial plexus. Now, in the axilla you have 3 chords: lateral chord, medial chord, and posterior chord. Medial chord continuing as ulnar nerve, posterior chord continuing as radial nerve, lateral chord continuing as musculocutaneous nerve. What about the median nerve? Median nerve is actually contributed by, let me show here. Now we can use some color which is different. I don't know which one to choose. Let us say black color only. The median nerve is contributed by lateral chord as well as medial chord. The medial chord giving some axons, lateral chord giving some axons, together forming the median nerve, and it runs in the midline, is a content of cubital fossa. So how the median nerve is formed? First of all, we should know the median nerve is called median nerve because it runs in the midline. Median. And how is it contributed? It is contributed by both the chords, lateral chord of brachial plexus as well as medial chord of brachial plexus. So lateral and medial chord together they contribute to median nerve. Where is it running? In the midline. That is why the name is median nerve. And is it a content of cubital fossa? Yes, it is a content of cubital fossa. You see here. So which nerves are content of cubital fossa? 2. Which one? Radial nerve radially, median nerve medially. And which nerve is not a content of cubital fossa? Ulnar nerve, because it passes behind the elbow joint. So ulnar nerve is passing behind the medial epicondyle, behind the elbow joint. It is not a content of cubital fossa. What is median nerve doing? Median nerve is supplying most of the muscles in the anterior forearm. It is the nerve of anterior forearm. Most of the muscles in the anterior forearm are supplied by median nerve. Plus, it will supply some hand muscles also, especially the thumb muscles, namely abductor, pollicis, brevis. So this median nerve is the nerve of anterior forearm, flexor muscles, and some muscles of the thumb, for example, abductor, pollicis, brevis. Otherwise, we have mentioned that most of the hand muscles are supplied by, most of the hand muscles are basically supplied by ulnar nerve. What will happen if I have a supracondylar fracture? If you have a supracondylar fracture, the nerve at risk of injury could be median nerve, especially branches of median nerve. So we have seen here fracture surgical neck of humerus, axillary nerve injury, fracture mid-shaft humerus, radial nerve injury. If it is fracture medial epicondyle, ulnar nerve injury. If it is supracondyle fracture, branches of median nerve can be compromised. How do you differentiate between these patients? You see this diagram and we can find out one of them is radial nerve injury, other is median nerve injury, and the third one is ulnar nerve injury. But how do you know that these patients which you are looking at belong to one particular category? As you can see now for yourself, loss of wrist extension, loss of extensor muscles of the posterior forearm, radial nerve injury. So when there is a radial nerve injury, the patient will present with wrist drop or loss of dorsiflexion, or loss of wrist extension. Where will be the sensory loss? Sensory loss is on the dorsum of the hand, 2.5, 3.5. There can be variation. sensory loss here. We will see a diagram and then discuss about the sensory loss. But dorsum of first web space will have definitely sensory loss because that is the area supplied by radial nerve. So if it is a radial nerve injury, you will have a wrist drop and sensory loss at least on the dorsum of the first web space. What about the median nerve? Median nerve, it depends that where is the injury. Say for example, we were talking about supracondylar fracture, or maybe you can just say median nerve injured at upper level around the elbow joint. So if median nerve is injured at upper level around the elbow joint, you may have what is called as hand of benediction at the level of elbow region. What is hand of benediction? What happens is if when median nerve is injured here, you will find it was supplying some anterior forearm muscle, especially lateral half of flexor digitorum profundus, which will fold these two fingers. To fold these two fingers, you need what is called as muscle flexor digitorum profundus, and especially the lateral half of flexor digitorum profundus. Now, since the lateral half of flexor digitorum profundus supplied by median nerve has been paralyzed, patient cannot fold these two fingers. Plus, patient cannot fold the thumb also. You see why? Because flexor pollicis longus, which fold the thumb, is also paralyzed, as it is also supplied by median nerve branches. So if median nerve is injured in the elbow region, you will find some of the flexor muscles in the anterior forearm have been compromised. Flexor pollicis longus, flexor digitorum profundus, especially for these two fingers. You are asking, in the question it will always be mentioned, you ask the patient to make a fist. But this happened. What is this happened? Benediction, hand of benediction. This is called hand of benediction, means inability to fold the thumb and these two fingers. But why you could fold these two fingers? When we want to make a fist, why this patient cannot fold these two fingers and thumb? Because median nerve injury, flexor pollicis longus not working, FDP lateral half not working. But how could he fold these two fingers? Because remember, these two fingers are controlled by medial half of flexor digitorum profundus, which is supplied by ulnar nerve. It is still working. It is a problem of median nerve injury. So it is a problem of median nerve injury, not the ulnar nerve. Ulnar nerve still working. These two fingers can still work. So when you ask the patient to make a fist, only these two fingers are working because ulnar nerve is working. These three fingers are not working, and this is called as hand of benediction. But how will I know that it is median nerve injury, hand of benediction, if I get the same patient here, which is actually ulnar nerve injury? In ulnar nerve injury, especially if you are talking about the ulnar claw hand, means injury somewhere here, wrist / injury, ulnar nerve injury, you'll find these two fingers are clawing, ulnar claw hand. Other three fingers are fine, but these two fingers are clawing. Why there is clawing? Due to paralysis of lumbrical interossei. Supplied by ulnar nerve, there is clawing. But this ulnar claw hand is appearing same as hand of benediction. How do I know that this is not ulnar claw hand? This is also ulnar claw hand. Disprove me. The difference between these two cases will be, this kind of appearance will come only if you ask the patient to make a fist. Normally it won't be evident. So this appears only when you ask the patient to make a fist, then it will appear. It is not always present. And what is this? This is always present. Patient will come to you like this. You are not asking patient to do nothing. It is always like this. This is ulnar claw hand. It is a deformity always existing. One thing. Second thing, in ulnar claw hand, there is hyperextension of MCP joint and flexion of IP joint. Hyperextension of MCP joint and flexion of IP joint. You will see that the MCP joint are hyperextending and interphalangeal joints are flexing. That hyperextension is not evident here. The MCP joint is not showing any hyperextension. So if there is no hyperextension, there is simple flexion, then it cannot be ulnar claw hand deformity. If there is hyperextension at MCP joint and flexion at IP joint, then it is going in favor of ulnar claw hand. So ulnar claw hand, median nerve injury and radial nerve injury. This is how quickly, just by looking at the patient at first go, 3 patients sitting in front of you, you are radial nerve injury, this is median nerve injury, and that is ulnar nerve injury. And median nerve injury, you have to ask the patient to make a fist, and then it happens. Hand of benediction. So I am hoping that this will be helping you a lot in dealing with the type of questions which keep coming. Along with that, you will also know that there should be some sensory loss. Talking about the sensory loss, we should understand this is the posterior view of the hand because nails are evident. This is anterior view of hand. It is to be understood that anterior 3.5 fingers, as you will find, it is becoming evident here. Let us take black color. This anterior 3.5 fingers will be supplied by the median nerve. And median nerve is not only anterior 3.5 fingers here, it is also going posterior to supply nail beds. 3.5 fingers. So 3.5 fingers nail beds means distal phalanx on the dorsal side is also median nerve. What about the remaining 1.5 finger? Now remaining 1.5 finger is ulnar nerve, maybe anterior or maybe posterior. So as we say, if there is ulnar nerve injury, you will have sensory loss in 1.5 finger anteriorly as well as posteriorly. Ulnar bone, ulnar nerve, medial cordobrachial plexus, lower trunk of brachial plexus, lower trunk of brachial plexus, medial cordobrachial plexus, ulnar nerve passing behind medial epicondyle, ulnar bone, ulnar nerve supplying most of the hand muscles, and skin on 1.5 finger anterior and posterior will be compromised if there is ulnar nerve injury. What about the radial nerve? Radial nerve is on the dorsum of the hand, as I mentioned, dorsum first web space, plus 3.5 fingers. But when you say it is radial nerve supplying the dorsum of the hand 3.5 fingers, it is minus the nail beds, because nail beds are already supplied by median nerve, which is supplying the 3.5 fingers anteriorly as well as posteriorly till the nail beds. Otherwise, middle phalanx, proximal phalanx. Middle phalanx, proximal phalanx, and this area all is under radial nerve. So you should know the sensory loss also, plus the dermatome. I told you, if it is little finger, C8 dermatome. If it is medial elbow, T1 dermatome. What is these middle 3 fingers dermatome? Middle 3 fingers dermatome is C7. And what is the thumb? It is C6. And what is the lateral elbow? It is C5. Lateral elbow, C5. Thumb, C6. Middle 3 finger, C7. Little finger, C8. Medial elbow, T1. What is this C5, 6, 7, 8, T1? That is the root value of brachial plexus. Brachial plexus has 5 root values starting with 5, C5. So brachial plexus has 5 root values starting with C5, C5. After that, 6, 7, 8, and then T1. Where is C5 dermatome? If you remember, axillary nerve till here. So C5 is lateral elbow, yes. And where is C6? The thumb. Where is C7? These 3 fingers. C8, this finger. T1, medial elbow. In Klumpke's palsy, where is sensory loss? C8 and T1. In Arm's palsy, where is sensory loss? Arm's palsy is a problem of upper trunk brachial plexus, C5-6. Upper trunk brachial plexus, C5-6. So, where is the sensory loss? C5-6? Yeah, where is C5-6? C5, C6. Means sensory loss on the lateral side of the upper limb? Yes. Lateral side of upper limb, sensory loss is C5-6. Arm's palsy. And in Klumpke's palsy, medial side of the upper limb. Medial side of upper limb, sensory loss in Klumpke's palsy. So these are some of the important topics which I thought should be discussed. 1.5 hours is over, and today we should stop here. Tomorrow we'll again continue from 6 to 7:30, this time going under the diaphragm, talking about abdomen, pelvis and lower limb. If you have any queries, kindly mention, we can discuss. Whatever we have discussed here, I am very hopeful that most of the questions which are about to come in your exam FMGE should have information which I am giving you right now in these sessions. I am very hopeful it should happen. I'll be happy, and of course you will be very happy. So tell me, snap box? You want to talk about snap box? Okay. I'll give you some brief information about snap box also. So snap box, normally what they are asking is the boundaries. You should know anterolateral boundary and posteromedial boundary. Now maybe it is anterolateral boundary or posteromedial boundary. They are the tendons of posterior forearm muscles, like extensor of the pollex, one long, one short. If it is extensor pollicis longus, it is posteromedial boundary. If it is extensor pollicis brevis, it is anterolateral boundary. I'll repeat again. Anatomical snap box is bounded by two extensors of the thumb, long and short. If it is posteromedial, it is longus, extensor pollicis longus. If it is anterolateral, it is extensor pollicis brevis. But then, remember, triple A also. And what is that triple A? Additionally, there is one abductor pollicis longus which is lying anteriorly. I'll draw the diagram now. So if you are talking about anatomical snap box, let me draw the diagram. Say this is the anatomical snap box. You want to know boundaries. So they are muscles of posterior forearm, like extensor pollicis longus tendon is coming here. Now extensor pollicis longus is a posteromedial boundary. Posteromedial boundary. Extensor pollicis longus, muscle of posterior forearm. But a muscle of posterior forearm only, which is extensor pollicis brevis, is going anterolaterally. So anatomical snap box is bounded by two extensors of the thumb. What is this triple A? If you are talking about this triple A, some other color, maybe this color. Triple A. What is this triple A? The first A is the name of the muscle abductor pollicis longus. Abductor pollicis longus. And what is the second A for? Let me use a distinct color here. Okay, so what is this triple A? The first A is name of the muscle abductor pollicis longus. And what is the second A for? It is additional boundary. Means it is not the true boundary, it is just additional boundary. The true boundary is extensor pollicis brevis. And what is the third A for? Third A is, it is more anterior. Anterior to what? Anterior to extensor pollicis brevis. Wherever the extensor pollicis brevis is, it is more anterior to that. So triple A. Abductor pollicis longus is an additional boundary and is anterior to the tendon of extensor pollicis brevis. Means here, if this is extensor pollicis brevis, it is much more anterior to that. Now these two tendons can be inflamed. Sometime they'll ask you a question, and that inflammation is called as de Quervain vaginitis. Which two tendons inflamed? The abductor pollicis longus and extensor pollicis brevis. And if these two tendons are inflamed, what is the problem? Problem is dequervain tendovaginitis. One test becomes positive. Sudden ulnar deviation is painful. Why sudden ulnar deviation is painful? Because these two tendons are inflamed. What is this test called? Sudden ulnar deviation being painful? That is called as Finkelstein test. So Finkelstein test become positive in dequervain tendovaginitis. And which tendons inflamed? Actual tendon, extensor pollicis brevis, and additional tendon, abductor pollicis longus. Both of them get inflamed. So that is all we wanted to take care of in today's session. All the best, take care, and we'll continue tomorrow evening at 6 p.m. Thank you.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe